Yes, it's important that physicians know at this time that it is very important for public health to know accurately the number of people who are being hospitalized and who are dying from influenza. To meet this need, I signed a temporary emergency rule last week that mandated physician reporting of all influenza-related deaths. So prior to this, the mandate was only for pediatric deaths, that is those who are 18 years of age or younger. That had been rule in North Carolina since 2004. We are now having a temporary rule where all influenza deaths are now mandatory reportable diseases, and you should call your local health department if you have a suspected death due to influenza in any age group in your practice. This is a temporary rule, and we are setting it to expire in 90 days when the H1N1 emergency we think will be passed. The other things we'd like for physicians to know is that the H1N1 vaccine will soon be available. Again, it's late September. We're anticipating delivery by early October for distribution to our vaccinators by mid-October. It's going through our normal vaccine distribution system through a vendor called the McKesson Company that normally delivers our vaccine from the CDC. Providers can sign up to administer H1N1 vaccine if they haven't already. You need to contact your local health department if you want to be a vaccinator and you have not yet signed up. You must agree to sign the agreement that we have, which says that you will vaccinate only the target groups unless public health changes the guidelines. And you must order at least 100 doses. That's the minimum amount necessary for it to be delivered to your office. Some local health departments are, however, allowing physicians to order less than 100 doses if they order it through the health department, and the health department will then deliver those smaller orders to your practice. However, you must call your local health department to see if that's the case for you. The other important item, again, is to remind providers on the proper indications for antiviral use. These have been published widely on our website, but it's important, again, to reinforce the fact that oseltamivir or Tamiflu or its inhalable cousin drug, Relenza, or Zanamivir, should only be used in people who are either suffering from severe disease, that is, they're hospitalized with influenza-like illness, and you suspect that they have flu, or that they have underlying conditions that you would predict that they may have a bad course, or have some other risk factor for severe disease. By and large, antivirals should not be used in otherwise healthy people. We've already documented a couple cases of Tamiflu resistance in North Carolina when the drugs were used in otherwise healthy children. The targeted population for the H1N1 vaccine right now is mainly children between the ages of 6 months up to young adult age of 24 years, household contacts of people or daycare contacts of people who care for children who are less than 6 months. This is to protect that 6-month-old who cannot be vaccinated, healthcare workers, and people between the ages of 25 and 64 years who have underlying conditions who would have a predictable poor or worse outcome if they were to get influenza. These conditions include, among many others, diseases such as diabetes, chronic lung disease, chronic heart disease, cancer or its treatment for cancer, people who are on chronic aspirin therapy, who, if they were to get a flu-like illness, might go on to develop Reye's syndrome, and others in those sort of risk categories. And of course, it's important to remember that pregnant women are also in the targeted population to receive the H1N1 vaccine. We have already shown in published reports that pregnancy is a risk factor for hospitalization, with hospitalization rates 3 to 4 times higher than the normal general population. There is a lot of information floating on the internet and in other sources about the safety concerns with the new H1N1 vaccine. Some of these are of reliable source, others are less reliable. The important thing to note about vaccine safety is that with all medications and vaccinations, safety is #1 concern. In the clinical trials, so far in thousands of patients, all that has been seen has been some pain at the injection site in the arm, which is what we would normally expect. However, it's important to note that there is a good surveillance system, and we encourage reporting of any adverse events that you feel are reportable. Going online and doing this on the web is the best way to do it, using the FDA Reportable Vaccine Adverse Event Reporting System. That's VAERS.org, VAERS.org, to report any adverse events that you think are clinically significant on the FDA website. And finally, this is not really an experimental vaccine. It is being made the same way that seasonal vaccines are made. It is simply a change in the viral strain. So the viral components are of the H1N1 pandemic strain. Everything else is the same, and the FDA is treating this as a strain change vaccine and not an experimental new vaccine. The other issue that is emerging with the clinical trials is that in otherwise healthy adults, it appears that one shot is enough. That is, one shot confers good immunity so that a booster is not necessary. However, the clinical trials are ongoing in all the other age groups, as well as using all the different formula preparations that are out there. There are the single-dose vials, the multi-dose vials, there's the live attenuated virus vaccine. All of these clinical trials you need to keep up to date on, but currently, from what we know, with the killed virus vaccine that is injectable in a healthy adult, one shot appears to be enough. We're encouraging everyone who normally would get the seasonal flu shot to go ahead and get it now. It is available at most places. And then you can go ahead and get the H1N1 if you're on that target population afterwards. So regular seasonal flu shot now. When H1N1 is available and you're in the target population, you can go ahead and get it next month in October. The trials have so far shown that there's no interference on getting both, at least in the flu shot form. However, if you do get the live attenuated viral vaccine, the MedImmune seasonal virus, you must wait 30 days before you can get the H1N1 after the live attenuated seasonal viral vaccine.